had a second position in the first UA-ISA con that was conducted way back. First position in the e-poster at second UA-ISA con. I think I can just say what are the years she didn't get a prize rather than telling which year she got a prize. So that will cut down our thing. But just to highlight it, not to undermine it, she had thoroughly deserved it and worked her way out of it. So I really feel all the postgraduates will be hearing it live. That is a different experience altogether. But whoever will get onto our lecture later also will definitely agree with what we have been trying to concise in a short period, the brief introduction of Dr. Meenal. So without wasting further time, I graciously invite Dr. Meenal to kindly start over.
Thank you so much, Dr. Aditya, for this very, very kind introduction. I'm audible? I'm audible properly? Okay, yes. Okay. So thank you so much. And as I just came to know, you're traveling to Delhi tomorrow, so you're very welcome to the North India.
Thank you.
Right. So I'll just share my screen.
Yes.
Is it visible? Is my screen visible?
Your screen is visible, Dr. Meenal. Yeah.
Okay. Right. So a very good evening to everybody who is present here. And so the topic which I'm going to take today is ischemic heart disease patients for non-cardiac surgery. Now, most of you, I think, are, if I'm not mistaken, maybe PGs. There are also a lot of freelancers who are joining. So, I'm going to go in a little detail because there are PG students here with me. And before starting, I would like to thank Dr. Ratnakar, sir, and also Dr. Reddy, sir, for giving me this opportunity, this platform. And this is a topic which is very close to my heart. I am not a cardiac anesthetist. I'm a general anesthetist who's also working in the ICU. So this, I bring greetings to you from Haridwar, where I work. This is my place of work, Metro Hospital and Heart Institute. So I have, right now, I am a corporate person, but I've also been a freelancer. So I understand both sides of the coin, basically, because the issues are very different in freelancing and corporate. So being a tertiary care hospital, it was very difficult for us to bat patients away. You understand, like no matter what kind of patients are coming to you with whatever ejection fraction, because there is state-of-the-art facilities available there to optimize those patients, we cannot refuse anybody or any surgeon from doing any surgery. So that is where this topic becomes of great interest, because you will get all kinds of patients from ASA grade 1 to ASA grade 4 patients. So let's begin. Now, who are these cardiac patients? The ones who are having ischemic heart disease, heart failures, valvular heart disease, cardiomyopathies, heart blocks, arrhythmias, congenital heart diseases, both adult and the pediatric kind. So they form 32% of the global burden. But because we can't cover all of them together in one lecture, we will need to divide it into different lectures. I'm going to cover only the ischemic heart disease in this particular lecture. This is going to last for about half an hour to 40 minutes. And after that, we can have as many questions as possible. Okay. So what kind of risks do you think you expect these cardiac patients to end in when you are taking them for surgery or when you're giving them anesthesia? These are major acute cardiac events, short formed as MACE, M-A-C-E. So these are the various kinds of problems which can happen. Either these patients can have arrhythmias, which can be the ventricular fibrillation kind, which can be the shockable rhythms, non-shockable rhythms. They can end in a perioperative MI, a partial heart block, which gets converted to a complete heart block, a heart failure, which goes into pulmonary edema. Anything like this can happen. So these are major acute cardiac events. There are certain pointers I'll give you. Please remember them for the sake of your discussion, in future. Then there is a new entity called as MINS, which is myocardial injury after non-cardiac surgery. This has recently been published in 2019 AHA scientific statement, and also in the 2021, AHA scientific statement. So according to this, the perioperative mortality in any patient who is more than equal to 45 years of age and is undergoing any major surgery is anyway 1 to 2%. Now, MINS is something called as, it happens, it is a myocardial injury which is happening in patients who may be having a cardiac disease or might not be having a cardiac disease. So 20% of the patients who are undergoing major surgery end up in MINS, which is a huge number. Now, what exactly happens in MINS? So here, these patients have elevated cardiac troponins, which is more than 99th percentile. Okay, and this happens within 30 days of giving anesthesia and getting the surgery done. Mostly it happens within the first 2 to 3 days only, but they have given a large period of 30 days. Okay, so here basically a large number of these patients do not have any symptoms. They will not have any kind of ECG changes, symptoms. Only the cardiac troponins will be raised. So this is a matter of great concern, that if somebody who is not having any cardiac disease can end in MINS, then imagine somebody who's already having a cardiac disease. So these are all the factors which are resulting in MINS, basically, the myocardial injury after non-cardiac surgery. If because of us, the patient gets hypertension or tachycardia, all this leads to myocardial oxygen supply demand mismatch, and that is the reason MINS occurs. So now, what are basically the parameters which you are going to search for when a patient comes to you for a surgery, a non-cardiac surgery? Okay, now there are patient factors and there are surgical factors. So let me start with the surgical factors. The first, when a patient is coming to you, you start with your PAC, right? That is the first thing which you do, a pre-anesthesia checkup. You start with the type of surgery. Now, there is something called as the timing of surgery, which is divided into 4 times. The emergency surgery, which occurs within 6 hours. So here, your life or the limb of the patient is threatened if the surgery does not happen within 6 hours. It can be something like a perforated gut or a stab injury. Then we have urgent within 6 to 24 hours. Now, the same perforated gut, which is in sepsis or a stab injury where the patient is bleeding a lot, if it is optimized, it becomes an urgent surgery. Basically, you have to understand that. Then you have something called as a time-sensitive surgery. Most surgeries are lying in this: orthopedic, laparoscopic, onco, all of them. Delayed surgeries are something which can be plastic surgeries, which can be delayed up to 1 year. So these are the 4 criteria: emergency, urgent, time-sensitive, delayed. All the definitions have been taken from the 2014 ACC-AHA guidelines. Okay, there are also European guidelines, there are Canadian guidelines, but I have stuck to the latest 2014 ACC-AHA guidelines. Next, we come to the invasiveness of the surgery. Okay, which means you have a high-risk surgery and an elevated risk surgery. The high risk is when the cardiac death or non-fatal MI can go up to more than 5%. Now, these are surgeries like the vascular surgeries, peripheral vascular diseases, aortic aneurysms, etc. And intermediate risk surgeries are those which are between 1 to 5% risk. Most of your intrathoracic, intraperitoneal, orthopedic, laparoscopic, all these surgeries are coming in the intermediate risk surgeries. Low risk surgeries are less than 1%. Endoscopic, cataract, breast surgeries are coming under low risk. So if you see this table, you have low risk and elevated risk. This is what the 2014 has. They have done away with the intermediate and high risk. Now they call the intermediate and high together as the elevated risk. So anything less than 1% and more than 1%. Okay. So this is the classification. Now, when the patient comes to you, so these are the surgical factors. Now, what are the patient factors? You start eliciting the symptoms. So what are the symptoms? Obviously, I'm going to talk here mostly about the heart-related symptoms. There can be chest pain, dyspnea, palpitation, syncope. Now, all of this is what also constitutes the acute coronary syndrome. But if all of this is unstable, happening at rest, if it is leading to heart failure, if it is leading to arrhythmias, then it becomes a grave matter of concern. Then we elicit past history. Is there any associated comorbidities like diabetes mellitus, chronic renal failure, cardiovascular accidents, cerebrovascular accidents, Okay, see, all these three are extremely important because later on you'll come to know that risk stratification becomes very important. Has there been any past history of coronary revascularization, which can be two kinds? Either a CABG has been done or stents have been put into place. Okay. Then also signs, any signs of, a failed heart, a heart failure. What are the signs of heart failure? A raised JVP, gallop rhythm, basal Krebs, edema, all of this. Any murmurs which are present, S3 heart sounds are present, heart rate is going tachycardia, BP is going very high. So all this needs to be thoroughly looked into. Now, all of these cardiac symptoms also get divided into intermediate or low risk symptoms and high risk symptoms. So intermediate or low risk are going to be all of them who come to us regularly. That after walking one flight of steps, we are feeling breathless, or two flight of steps, we are feeling breathless. We have intermittently, sometimes we have chest pain, all this. High risk is all of this. If there has been a recent history of MI, recent is within 30 days, or a recent history of a percutaneous intervention, which is within 6 months, an unstable angina, a decompensated heart failure, high-grade arrhythmias, valvular heart diseases which have some kind of hemodynamic changes. So all of this forms the high risk category of patients. Next, we start talking about the METs. That is what we ask them. How much do you walk? What all do you do? Do you walk on plain road? Do you walk up the hill? So that is what is a very subjective assessment. This is what they tell us. We don't have any objective parameter to measure it. So what is one MET? Metabolic equivalent is 3.5 ml oxygen uptake per kg per minute is 1 MET. This is resting oxygen uptake in sitting position. So 1 MET is when the patient is able to sit, eat, dress himself up and use the toilet. That is 1 MET. But here, when the patient is able to achieve 4 METs, it means that there is a very good prognostic indicator, which means that, the patient has good effort tolerance. So what is the achieving of 4 MET standards? It is when a patient is able to walk up a flight of steps, up a flight of steps or a hill at 3 to 4 miles per hour or 5 kilometers. So, normally we know about kilometers per hour. So if somebody is able to walk 5 kilometers per hour at a regular pace for a little longer time, then that is what is 4 METs. If they are able to do heavy work, scrubbing, moving furniture, and climbing 2 flights of stairs, then it's 4 to 10 METs. And when you're doing very strenuous sports, it becomes more than 10 METs. Now, there was a Lancet study which was done to compare this subjective assessment, which is METs, with the with the objective assessments. So objective assessments are what? The CPET testing, cardiopulmonary exercise testing, or the DASI questionnaire, the Duke Activity Status Index questionnaire, and all the biochemical profile. The biochemical profile will be N-terminal pro-B type natriuretic peptide, which is pro-BNP and NT-pro-BNP concentrations. Okay, this was done to predict complications, major complications after major elective non-cardiac surgery, even death. So they did the study where they compared the subjective parameters with the objective parameters. And what did they find out? So this is a DASI index, okay, DASI questionnaire, which has 12 questions. It gives marks for every question, points for every question. You add it up. So it has very, can you run a short distance? Can you participate in strenuous activities? Can you walk indoors? All of this. So what they found is that anybody who had a DASI score of less than 34 was associated with an 30-day moderate to severe complications risk. Within 30 days, such patients can even end up in death, MI. Okay, so DASI scores were found to be better at predicting the major cardiac complications than the METs. Why? Because METs were more subjective. So METs had low sensitivity, only 19% sensitivity, while DASI had higher sensitivity because it was more objective. Even more objective was CPET, the cardiopulmonary exercise testing. So cardiopulmonary exercise testing is by itself a huge topic, which will take 10 minutes to explain. In short, I can just tell you this much, that in CPET, you are trying to measure everything from, you're trying to find out about the respiratory status, cardiac status, skeletal muscle status, the oxygen carrying capacity status, the hematopoietic status, everything through various tests. So it is a very objective way of measuring. There's a beautiful article, you can read about it. There's a beautiful article in the BJA journal on CPET. It's for 2 to 3 pages, and I'm sure the postgraduates will benefit. Now coming to the objective assessment markers which we use for cardiac activity, or the objective assessment criteria which we use. There is something called as the RCRI index, or the Revised Cardiac Risk Index by Lees, which is being used very frequently. This is the most common one, developed in 1999. Then you have the MICA calculator, which is the Gupta MI cardiac arrest calculator, and the NSQIP is another very common one, which is the American College of Surgeons National Surgical Quality Improvement Plan calculator. See, NSQIP and MICA, these two are available online, and they have a huge number of questions. You can put all the data, even the kind of anesthesia influences, the drugs which you're giving influences, the timing influences, everything. The RCRI, which is Revised Cardiac Risk Index, is simple, which can be used by you and me very easily while doing the PAC. So my take-home message is to start implementing the Lees RCRI while you're doing your PAC. So this is what it is. There are 6 parameters. A high-risk surgery, I just told you what is a high-risk surgery, right? So all those aortic aneurysms and all of that comes under the high-risk surgery. History of ischemic heart disease. Now this I'll come to later, but just keep it in mind, okay? History of congestive heart failure, cerebrovascular disease, a diabetic on insulin treatment, very important. Okay, and a preoperative serum creatinine of more than 2 milligrams per deciliter. The same thing in NSQIP changes to more than 1.5 milligrams per deciliter. These are small. So 1 point is given for everything. Now you see here, even if 1 comes positive, more than 1 comes positive, that means even if 2 are positive, the patient comes under the moderate risk, which is a huge risk. 7% is a big risk. Okay. So what exactly is history of ischemic heart disease? Is it just when they come and talk to you and tell you about that, I'm getting this pain while walking or all this? No, it is this. History of ischemic heart disease is history of MI, which is recent, which is 30 days, within 30 days, or a positive treadmill test. Right now, the patient is having chest pain. Right now, the patient is using nitrate therapy, and right now, there are fresh Q waves which have appeared on ECG. So all of this comes under history of IHD. Okay. So so what does this Lees criteria basically determine? It determines again the major acute cardiac events, which I just told you in the beginning: the MI, pulmonary edema, fibrillations, heart blocks, and even cardiac arrest. Now, this is a very important point, the last point. Please remember this, that if the patient has had a previous coronary revascularization, which can be a CABG or a stenting, whatever kind of revascularization, if the patient right now is not having any chest pain, is not on nitrate therapy, is having good effort tolerance, it's been more than 6 months, there is no reason to put this patient in a high-risk category. So do not be scared to operate any such patients with stents. Do not be scared to give anesthesia to any such patients with stents. Okay, next. So this is like an NSQIP calculator, which you can see, and this is available online. Okay, so why do you basically need this risk stratification? Okay, now very necessary, because it only when you're able to give these indices, you will get a percentage of complication rate. And only then you will be able to explain to the patient party, even your surgeon, about certain things, about the risk-benefit ratio. One thing I'll tell you, right now, the Supreme Court has said that it is only the patient who is supposed to give consent. So related to that, you have to explain everything to the patient, unless it is giving you some kind of therapeutic privilege to hold back that information and only tell it to the party. This will help to optimize the time of surgery. Do you require further testing? Should you postpone? Are there any alternatives to this? Is there a less risky procedure, or should we just cancel the procedure and go for a intervention rather than doing that particular surgical procedure? That is why these kind of parameters become extremely important. Okay. Next, what are the cardiovascular tests which are available? So in any patient who is coming to you with a known cardiac disease or a suspected cardiac disease, you definitely have to do a 12-lead ECG, whether you're going to get that patient operated or not, whether you're going to give anesthesia or not, but a basic 12-lead ECG is necessary. Beyond that, we come to the next level of investigations. So you have a 2D echo to see the LV function, ejection fraction, regional wall motion abnormalities. Now, when do you do a 2D echo? So many a times the use of 2D echo is rampant, and it is sometimes unnecessary also, at least in corporate setups, many a times. So basically you do a 2D echo for these 4 things: when there is dyspnea of unknown origin, when there is a worsening dyspnea, when there is prior heart failure, or there has been a previously documented LV dysfunction which has not been assessed in a complete year. For example, there was a patient who came to me who had a history of cardiomyopathy, and he said that 1 year back his ejection fraction was 2 years back he had this cardiomyopathy dilated. That time his ejection fraction was 40%, and 1 year back he did it, it has improved, it has become 50%. So now he has come for some kind of surgery. I don't remember, maybe inguinal hernia or a hydrocele. So I asked him, where is your recent 2D echo? He said, no, I got it done 1 year back. So in that situation, this becomes important, because 1 year back echo is not going to hold importance for you here. The next kind of test is the stress test, either the TMT, okay, where you make the patient walk on the treadmill, or the pharmacological testing, which is through dobutamine or dipyridamole. Dobutamine is used. That is the pharmacological stress test. It mimics the TMT. It basically increases the heart rate without the patient having to exert on his own. Then I spoke about these biochemical markers or tests. So you have something called as the preoperative BNP and the preoperative anti-PRO-BNP, which is even more sensitive. So you have to remember these, because these are now being used in a large way. The pre-op BNP, whenever patients are extremely dyspneic and they are into heart failure, the pre-op BNP will go more than 400 for sure. If this pre-op BNP is less than 100 picograms per ml, then this is negative for LV dysfunction. This is a negative predictive value for LV dysfunction. If the anti-PRO-BNP is less than 300 picograms per ml, then that is again negative predictive value for any kind of heart failure or LV dysfunction. See, normally the normal plasma concentration of the anti-PRO-BNP is 10 picograms per ml. And it rises 4 times, 5 times. I've also seen, values of 2000, 2500. So now somebody might ask that when do you do a troponin testing? So if you think a patient is very dyspneic, if you think a patient is having all signs and symptoms of heart failure, get a BNP or a pre-op anti-PRO-BNP done preoperatively. You will have those baseline values, and then I will come to the flow chart later on. I'll tell you about that, how to go about it. But say you have finished with the surgery, you've finished with anesthesia. Now, such patients who had higher BNPs of more than 100 and anti-PRO-BNP of more than 300, they will require routine troponin surveillance 48 to 72 hours after surgery. You will have to give them, now this is from the Canadian journal, this is from the Canadian guidelines, Canadian Heart Guidelines of 2017. Okay. So important point. A little bit about what is the class of recommendations. Okay. Now a lot of times, we don't understand it. We don't read it properly, but it's necessary to read because we are following the AHA ACC guidelines. Okay. So for any recommendation, it can be a drug, it can be a procedure, it can be a surgery, it can be an intervention. Class 1 means that there is enough evidence to prove that what you're doing is absolutely useful and effective. Class 2 is divided into 2A and 2B. So 2A means that much more usefulness is there. Class 2B is less usefulness is there. but it is still useful. Class 3 is when that particular procedure or treatment or intervention is actually not useful, it is harmful. So that is classification of recommendations. What is evidence? Level of evidence is evidence A, which means multiple RCTs have been done. Evidence B is single RCT, and evidence C is just a few experts are sitting and forming these rules and regulations. See, evidence A was seen in the recent, ISA has published the recent preoperative guidelines, preoperative investigation guidelines, that is evidence A, when they have taken large number of randomized control trials. So now we come to this algorithm, which is the basis why I spoke so much before this. Okay, this is what you need to do when the patient comes to you. So I'm going to start breaking it up and telling you. Now, what is step 1? So, Nala, I would want all of you to just pay a little attention here. So a patient comes and is posted for a surgery, and he has risk factors for coronary artery disease. So step 1 is, there are risk factors, okay? So is this an emergency surgery or is it not an emergency surgery? If it is an emergency surgery, then you are going to just stratify the risk, put it in the Lees index or the NSQIP, talk to the patient, party, everyone, and guideline directed medical therapy, GDMT, and you will just proceed with the surgery after maybe taking a high risk consent, or sometimes you will also explain death on table. Death on table consent is not taken, you explain death on table and you take a high risk consent. Okay. But this is step 1. Now, if this is not an emergency surgery, it becomes step 2. So then you ask yourself, I mean, you find out from the patient, is he having any acute coronary syndrome? Acute coronary means right now at rest, palpitations, dyspnea, chest pain, nitrates, Q waves, fibrillations, or some kind of arrhythmias, etc., etc. Yes, then you better not take the patient for any surgery. You refer the patient to the cardiologist, let him give the guideline directed medical therapy. It can be beta blockers, it can be amiodarone, it can be whatever they need to optimize, whatever other investigations they need to do, but you should hand over such a patient to the cardiologist. If there is nothing like this happening, then comes step 3. Now, this is the difference. Now, try and understand what difference comes here. This difference is, rather than beginning to ask them about meds, please start estimating the perioperative risk of major acute cardiac events by using your risk indicators, the RCRI indicator, the NSQIP indicator, the combined risk of surgery and patient factors. If that risk score is less than 1%, which I told you initially, then no further testing is required. You just proceed with the surgery. You have a baseline ECG and you just proceed with the surgery. But if there's elevated risk, more than 1% risk, it can be 1 to 5% or more than 5%. It can be any kind of risk. Then in that case comes your step 5. Here is when you have to start talking about the meds, the metabolic equivalent. So the objective comes first, then you go to the objective criteria. So then you go to the subjective criteria. So this is the subjective criteria. Now you start talking about the meds. So now you ask them, what is the functional capacity? If it is good, more than 10 or 4 to 10, you can proceed with the surgery. There is no other testing required. Step 6 becomes, if the meds are poor or unknown, or the patient is bedridden, not able to move, in that case, you should go for pharmacological stress testing, which is a class 2A recommendation. If it is normal, then you can go ahead with the surgery, which is with the guideline directed medical therapy. If it is abnormal, this pharmacological stress testing, the patient requires a coronary revascularization. This is very confusing. I'll just do it again with you people once. Okay, so step 1, a patient, known history of CAD comes to you. You ask the patient, is it an emergency? You find out, is it an emergency surgery or a elective one? If it's emergency, just do risk stratification, counsel the party, counsel the patient, go ahead with the surgery with all the required anesthesia, techniques or precautions which are to be taken. If step 2, if it is an acute coronary syndrome, yes, then just refer the patient to the cardiologist. Third, if it is not an acute coronary syndrome, then just estimate the risk of MACE, major acute cardiac events, through various parameters. You have all those indexes. If it is low risk, just go with the surgery. If it is elevated risk, then do the subjective METs analysis. If METs are more than 4, go with the surgery. If METs are less than 4, go for pharmacological stress testing. If it is normal, proceed with the surgery, but guideline directed medical therapy, means all our anesthesia protocols in place. If it is abnormal, go for coronary revascularization. You have to read it 2-3 times to understand it. So what are the changes in the anesthesia techniques which we are going to adopt so that these patients do not get compromised any further? Now, one thing you have to understand, that clinical outcome is not significantly influenced by the kind of anesthesia technique. You can give GA, you can give spinal, epidural, regional blocks, sedation. But if you're able to maintain all of this, avoid tachycardia, because that decreases the diastolic relaxation time. Okay, it puts more, effort on the heart. It puts more load on the heart. If there is hypotension again, it is going to decrease the coronary vascularization. So stress response has to be avoided. You have to blunt it. Epidural blunts it. Even if you're giving a GA, you have to be very careful that during induction, during your extubation, during incision, or even there's a port entry, there is no sudden tachycardia. Avoid hypoxia, hypothermia. There has to be very good pain relief for the patient so that they are not wailing and whiling away in pain. That's why the use of nerve blocks becomes important. They can be even landmark guided blocks. For example, you can give a tap block even if you don't have an ultrasound. Okay. Judicious use of fluids, and sometimes if needed, inotropes also need to be used to keep up, to maintain the MAP. The MAP is mean arterial blood pressure. So this is a chart which I would want to show. So how much tachycardia, how much damage tachycardia can do. You have to aim the heart rate to be between 60 to 80, 60 to 70, 65 to 70, 80, that's it. So if you see, if it is going more than 80, it is still the odds ratio, you can see it is just decreasing and decreasing and increasing this way and that way. So 80, 90, 100, it is becoming a problem. But if it is remaining less than 80, say about 60 to between 60 to 80, 60 to 70, it is much acceptable. Coming to the BP, the blood pressure. The blood pressure map also has to be around 65. There are few studies which are saying about 65 to 70. The first graph, if you see, at about 70, you see that the estimated probability of the myocardial injury after non-cardiac surgery is really low. Okay. And as it starts increasing, it starts going up. If it is very low, that hypotension is also bad, hypertension is also bad. Okay. And how much can it fall below the standard blood pressure? It can fall about 20 to 30% below the baseline. That's it, not more than that. Okay, coming to certain drugs. So if these patients, so there was a study, okay, there was a POISE study. POISE study actually spoke about beta blockers. They said that if beta blockers are given, then it really improves the outcome of the patient. But if beta blockers are already going on, only then. You should not introduce beta blockers 1 or 2 days before the surgery. Okay, so if they're already going on, continue. ACE inhibitors, angiotensin receptor blockers, all continue for blood pressure. Statins, definitely one of the best drugs to be continued. Clonidine also to be continued. Now, clonidine does not basically avoid any cardiac complications. Beta blockers avoid postoperative cardiac complications. Okay, but clonidine, because it's a good antihypertensive, it's a centrally acting pain reliever, so it is by itself, it has a good effect. Also, the calcium channel blockers, diuretics, all of them need to be continued. Now, what about the aspirin? So aspirin has to be continued if patients have had coronary revascularizations of any kind or carotid end arterectomy. Otherwise, you need to stop it about 5 days before any non-cardiac surgery. Okay. I don't stop most of the times. I stop clopidogrel. I don't like to stop aspirin basically. But that's a different chapter altogether. Regional, there are regional guidelines, ASRA guidelines about how to go about it. We will not go into those guidelines. That's another topic altogether. Now, those were the 2014 guidelines of ACC-AHA. Now, this is one guideline which has come in 2016, I think. This is those patients who have already undergone a percutaneous interventions, which means stenting. Now they are coming for elective, not emergency, elective non-cardiac surgery. So there are two kinds of patients. Either they are having the bare metal stents and they are on dual antiplatelet therapy, or they are having the drug-eluting stents and they are on dual antiplatelet therapy. So patients who are having bare metal stents, if it is less than 30 days since implantation, you cannot do the surgery. It's because it's going to harm the patient. Because to do the surgery, you need to stop the dual antiplatelet therapy, and that's definitely going to harm the stent. Very few places bare metal stents are being put. So it's just, I'm just giving a theoretical literature on this. If it's more than 30 days, then of course you can proceed with the surgery. Now coming to drug-eluting stents, which are put everywhere, mostly. If less than 3 months, you cannot stop the DAPT. 3 to 6 months, then you have to see the risk-benefit ratio. So is discontinuing DAPT going to be more harmful than delaying surgery or vice versa? Again, this is a decision which the surgeon, the cardiologist, has to take collectively. Okay. And you can proceed with surgery in case if you think the surgery needs to be done. If it's more than 6 months, since the drug-eluting stents, definitely you can discontinue the dual antiplatelet therapy and proceed with the surgery and start the dual antiplatelet therapy as soon as possible after the surgery. It's not going to have an effect, a bad effect on the patient. So this was my presentation. Now I'm going to talk about a few case scenarios, and if there are people who would want to answer, they can answer, or otherwise I am going to go ahead with it. So 60-year-old male, now every word is important, so listen to it carefully. 60-year-old male comes with history of perforation peritonitis. Now this patient is also having sepsis. He is a known case of ischemic heart disease. He's having dyspnea at rest, T-wave inversions in anterolateral leads on ECG, and he's posted for laparotomy. How will you proceed? So let us go by the flow chart. The first thing is he's having perforation peritonitis and having sepsis. So obviously this patient is needing an emergency surgery. So if he is needing an emergency surgery, even if he's having IHD, dyspnea at rest, which is acute coronary syndrome, you're having T-wave inversions, they're having, all of this, you are still going to take a high risk consent. You are still going to involve a cardiologist. You are going to give her guideline directed medical therapy, the kind of anesthesia. Maybe you'll use etomidate, maybe you will, and you're going to start him on beta blockers as advised by him, but you have to go ahead with the surgery. There is no question of postponing this surgery because this patient is having acute coronary syndrome, because here his life-saving procedure needs to be done. He's going to die of peritonitis. So this is case 1. Case 2. 60-year-old male is coming with history of right inguinal hernia. Patient is having history of ischemic heart disease, dyspnea at rest, and presently on nitrates. Now this patient ECG is showing T-wave inversion in anterolateral leads. Now patient has come for laparoscopic hernia repair. How will you proceed for this surgery? So again, in this case, I don't know if anybody wants to try it. Is there anybody who wants to answer? Okay, I'll go ahead.
Yeah.
Okay, so I will, yeah, Dr. Aditya, you're saying something?
No, I was just asking if anyone is interested to take this question.
Okay, Now, this patient is coming for history of right inguinal hernia surgery, right? This is not an emergency surgery. Definitely not. So first step, you remember, emergency or elective. So this is an elective surgery. Is he having ACS? Yes, he's having acute coronary syndrome. There's dyspnea at rest. He's on nitrates. There's history of, already there's a history of IHT. Right now he's having T-wave inversion. So the first thing, because you have to go and do is a 2D echo. That becomes absolutely important. And you have to get an ejection fraction of the patient, find out about the regional wall motion abnormalities. Why? Because he's having dyspnea at rest. It's a worsening dyspnea from before. Okay, and also refer the patient. See, there is this concept of we being perioperative physicians. For that, you also have to upgrade yourself. You must know how to do a 2D echo. You must know how to do bedside investigations. You must also work in tandem with the cardiologist. Till then, if like I'm working in a corporate setup where everything is available, so I would like to refer him to a cardiologist and let the cardiologist also pitch in and decide. So this is what I'm going to do a 2D echo, wait for what is coming into picture, whatever comes. If I'm not satisfied with it, also he needs some kind of guideline directed medical therapy, statins, aspirins, all of that, but that needs to be given by the cardiologist. So we will not proceed with this case presently. This is a multidisciplinary approach. Okay. Case 3. A 45-year-old female comes with history of cystocele and rectocele. Now, this is a case which happened today. So I just put it today only. Okay. Now, this patient has history of chest pain at rest intermittently. Okay. And severe dyspnea after climbing one flight of stairs. ECG shows T-wave inversions in lateral leads. This patient is posted for vaginal hysterectomy. How will you proceed? So, anybody who wants to take this? Okay. Now, this patient actually, earlier this patient had come for a PAC and there was a review PAC written. And the review PAC, she did not come back. She was posted directly today morning. So when I went and saw the patient, she gave me history of chest pain. There was ECG done. That's it. When she had come earlier, she was not giving history of chest pain. She must have come about 10-15 days ago. This chest pain was at rest. It was intermittent. It was not going up till the arms, but she was having severe dyspnea. She said she's not able to walk even few steps. This again becomes a matter of great, great concern. So now you have to again go in for a 2D echo. Okay. The 2D echo was done. The 2D echo was found to be normal. It showed some little diastolic dysfunction. The EF was about 45%. And rest, it was all okay. 45% is also slightly low, but it was 45%. So the next we went ahead was a stress test. Because she's giving very significant history, but nothing is coming on the 2D echo and on the ECG. I mean, ECG is showing inversions in lateral leads, that's all. But nothing is coming on the echo. So we went ahead with the stress test. And the stress test actually showed a lot of changes. There were changes. There was non-inducible ischemia was there. All of that was there. And so this surgery was postponed. Okay, next. Okay, now I just changed the scenario. Now this same patient, suppose, is coming with history of cystocele and rectocele. And this patient is having chest pain at rest, intermittently severe dyspnea after climbing one flight of stairs. Same thing. ECG showing T-wave inversions and lateral leads. Patient has associated diabetes on insulin treatment. Let us change one parameter here. Let us make this not dyspnea dyspnea and chest pain at rest. Let us make it a history of ischemic heart disease, which is a stable disease. As in, she is after climbing about 2 flights of stairs, she's having some kind of dyspnea, or she's having some kind of little discomfort. So now let us revise our algorithm. Not an emergency surgery, elective surgery. Vaginal hysterectomy is an elective surgery, but it's a time-sensitive surgery. Okay. Second, no acute coronary syndrome. Don't take as, so this is not an acute coronary case. Third, you have to calculate the major acute cardiac event risk. So if I start with the RCRI index, this patient is associated with diabetes, is on insulin treatment. So that becomes one of the important parameters, and because the surgery which the patient is undergoing is intraperitoneal, it is a large surgery, it is a intermediate risk surgery, that also becomes more than 1%, which is elevated risk. So there are two parameters which come here. So there is 2 plus means nearly 7% risk. 7% risk means it's a high risk. So a 2D echo is most definite in this particular case. And then you can proceed with the surgery. If the 2D echo is normal, you proceed with the surgery. If the 2D echo has some kind of disparity, then you go in for the next treadmill test. Case 5, a 62-year-old male comes with history of large ulcer on the dorsum of the left foot. Patient has stable angina. There is a known history of IHT, diabetes on insulin, creatinine of 2.1 milligram%, on ecosprin, on nifedipine, on atenolol, and osteoarthritis of both the knees. ECG is showing inferior wall ischemia. Patient is posted for ulcer debridement. How will you proceed? Too much of information? First and foremost, so this is not really an emergency case, but it is an urgent case, because these patients, who have ulcers and all, they might end in diabetic ketoacidosis anytime, or they might just lose their life anytime. So this is an urgent procedure. Now, this patient is not having acute coronary syndrome. Third is major acute cardiac events. So yes, there is diabetes, there is creatinine, the patient is, so these two parameters are again positive. So this becomes an elevated risk again. Okay. And also the patient is having osteoarthritis, so you're not able to judge the METs also. That is also a problem. So what would I do? I would take a high risk consent. Of course, I would do a 2D echo for this patient, find out the ejection fraction, etc. For me, if it's a smaller ulcer, if I can give a ankle block. So again, alternative strategies of anesthesia become important. What can you do alternatively? So I would want to give him maybe an ankle block. If that does not work, it does not help me, if I need to have a plan B, then I must know what is the ejection fraction of the patient. If the ejection fraction says less than 40%, I must know how to proceed, how much drug to give. If I want to give spinal, I can give spinal anesthesia. As I told you earlier also, that if you give a very low dose spinal, and if you just give a unilateral spinal, it is not going to have much of a, cardiovascular effect. Okay. Or you want to give a sedation. That is all up to you. So this is about it. So the take home message is this: you should know about that, even in normal patients, normal individuals who are more than 45 years of age and who are undergoing major cardiac surgery, who are not having any earlier cardiac problems, they are also having myocardial injury after non-cardiac surgery of the rate of 20% in major cardiac surgeries. You have to know what are the major adverse cardiac events: the ventricular fibrillations, pulmonary edema, arrhythmias, heart failures, MI, all of them. Objective assessment is more sensitive than subjective assessment. So please start including these indices in your day-to-day PACs. RCRI, easiest. Please take a picture of it and paste it somewhere. MICA, NSQIP if the patient is very high risk. Pre-op BNP values less than 100. Pre-op NT-pro BNP values less than 300. Both of them exclude LV dysfunction or heart failure. Now, this is an important line. The data suggests that if more than 60 days have elapsed after MI before non-cardiac surgery in the absence of a coronary. So if a patient is coming to you who has had a recent history of MI, if more than 60 days have passed, then you can take the patient for a non-cardiac surgery, even if no cardiac intervention has taken place, which means the patient is only on say ecosprin, statins, atenolol, etc. Nothing really has been done. And if the patient is stable, is having okay effort tolerance, 2D is fine, you can take these patients. And more than 60 days have passed. Okay. So drug-eluting stent, 3 to 6 months since putting it, the risk-benefit ratio needs to be mentioned, thought about, measured, spoken to. More than 6 months, you can go ahead. You can stop the dual antiplatelet therapy. If the patient is having any major acute cardiac events after non-cardiac surgery, You have to remember, like, there was this one case I precisely remember. We took the patient for total knee replacement, and that patient later on, everything was fine. That patient developed MI, post-operative MI. There was, and had to be kept in the CCU. So definitely these patients are having some kind of coronary artery disease preoperatively, which has been missed. Either it has been missed on ECG, or it has been missed on the 2D echo or history taking, or probably it's silent. Patient's age is an independent risk factor. More than 55 years, yes. More than 65 years, oh my God. Then that patient needs to be investigated properly and fully. Heart failure is an independent prognostic variable. If the patient is in heart failure, then of course. And severely decreased EF, less than 30%, is an independent contributor to perioperative outcome again. This is the last slide, which I will just want to tell my PGs here, sitting here, that how ECG becomes important. These are how recommendations become important. So you have class 2A. What was class 2A? Class 2A is when the benefit becomes much more, there's benefit of doing a particular procedure. Okay. So patients who are having coronary artery disease, arrhythmias, and all of this, cerebral vascular disease, all of them should undergo an ECG. This is a class 2A recommendation. Okay, except, so if they are undergoing intermediate or high risk surgeries, they are supposed to do it. 2B is also, 2B is for asymptomatic patients. Though that is for symptomatic patients. 2B becomes for asymptomatic patients which are having coronary artery disease. And class 3, that is no benefit. Routine's 12-lead ECG is not necessary for asymptomatic patients who are undergoing low-risk procedures, say a breast surgery, a cataract surgery, having nothing, asymptomatic, no, then why even do an ECG? So with this, I would like to end my presentation, and thank you so much, Dr. Aditya. I hope it was, people understood it.
I think it will take some time for them to sink in, but definitely a very elaborative and exhaustive way. As we always say, 10 anesthetists and 11 procedures. It's always a debate of gray areas, like what Dr. Meenal was trying to say. There is nothing like a hard protocol, but how do you plan up your, the way you are going to anesthetize the person is what matters. We have just given you a gist of what you need to take into consideration and what a standard protocol is giving us a direction. But as per your situation, you probably can modify if you are equally confident of handling it off. The only thing before I'll now open the session for any questions. If there are any in the chat box, I don't see any other questions.
Yeah, Dr. Dilip has made a very good point. He says that pro-BNP has good sensitivity but low specificity. Yes, sir, that's why we have the anti-pro-BNP, which is even better. And you're right that the post-COVID, even without the LV dysfunction, it is being raised. But then, so here we are specifically talking about the cardiac patients. So of course, yeah, we have to keep all of this. That way we have perioperative cardiomyopathies also. We are having so many of these young obstetric patients are ending up in, cardiomyopathies. That's there. And
as said, I think
okay.
BNP has a more better negative predictive value than a positive predictive value. And I think the unilateral segmental spinal, segmental spinal,
it's there.
Segmental spinal
the terminology is there. So but yes, you can call it preferential spinal. Yeah.
Now, only one thing I would like to differ slightly. I feel most important for all the postgraduates or any practicing consultant is not to blindly follow the 2D echo report, always take into the history and the effort tolerance of the patient into consideration, because that is where a stress heart gives you indication whether the ECG or is it going to be a turbulent ride or it's going to be a smooth ride during your intra-op. And regarding the routine ECG for all cases, it's a very gray area of discussion. You can stand on both sides, but my only concern or request is if you can ask for a pre-op baseline ECG, and anyhow we are getting a surgical profile done, it just gives you, we have stress cardiomyopathy and other conditions which land intra-op, probably a document to say that it's a stress-induced cardiomyopathy. But again, as I said, as Dr. Meenal also said, it all depends on stratification of your risk and what is the plan of procedure, what is anesthesia you're giving. So accordingly, we'll have to manage. Any other questions?
There is one thing I would like to say to the postgraduates here is that, we always talk about the effort tolerance. So this is what it was my discussion about, that start taking, as Dr. Aditya said, start taking all these risk indices into consideration. Start, working on the Lee's index and then the NSQIP calculators, and not just the METs, because METs are very objective or very subjective. So you have to learn to use them also. So that is one thing. And yes, there are proper indications for doing an ECG. So if it's a low risk surgery and the patient is asymptomatic, if you don't require an ECG, that's why you should know that classification. What is high risk, intermediate risk, and low risk? So if a patient is coming for breast lump removal and she's a young patient, 20, 25-year-old, asymptomatic, you need not do it. That is the thing. Okay. But then if you have a baseline, it is good. If the patient can afford it, but if you're working in a freelancing setup, so that is what is the thing. But yeah, a lot of gray areas. Yes.
And that's what you need to individualize to a situation where you are working in on. But again, these are just basic guidelines to give you a proper protocol on how to approach a cases more schematically. Any other questions?
Yes, sir. Good evening, sir.
Yes, sir. Kindly introduce.
Sir, Dr. Satyanarayan. Yes.
Yeah, Dr. Satyanarayan, sir.
Yes,
Hi,
sir.
sir.
Hello, sir.
Sir, role of calcium channel blockers in lab cases and cardiac compromise cases. Can you please elaborate the uses?
Uses. So calcium channel blockers should be given. Actually, they should be continued. See, the guidelines say that whatever drugs the patient is taking, whatever cardiac drugs the patient is taking, that should be continued. We should not stop it. Yeah, because it is not going to harm the patient in any way. So CCBs, ARBs, ACE inhibitors, all of this should be continued. The only concern is to not start a new beta blocker. Otherwise, CCB can be continued. Yes.
Can be used. Oh.
Yes.
Thank you. Oh, thank you.
Only one thing to add, sir. We do not want to use any short-acting calcium channel blockers, which may cause a reflex tachycardia. In a moderate case, it might actually be issues. So you can ask, you basically now even the guidelines are changed to extended release calcium channel blockers or a mild calcium channel blockers like selindipine and other things, where you can continue without having refractory hypotension.
Okay, sir. Thank you.
So any other question from anyone? If there are no questions, thank you, Dr. Meenal. It was a very thrilling session we had. Probably a lot of homework again to be done to the postgraduates to get into the zone of, classifying the scales, the effort tolerance, the May score, and the other different scores what you have elaborated, and probably better pre-optimization as well as intra-op optimization of any cardiac issue coming for a non-cardiac surgery. So at the outset, I would like to convey my thanks from ISA Telangana for accepting our invitation and honoring us with a very interesting as well as insightful lecture. Thank you so much.
Thank
you all for the
sir.
participation.
Thank you so much, sir. Thank you.
Right. So thank you, everyone. Good night. The link for the YouTube will be shared shortly.
Thank you, sir.